I'm Dr. Griffin.
And I'm Dr. Taylor.
Welcome, everyone. You are joining us for Evidence at the Bedside Board Review Edition.
Yeah, so glad to have you all here.
If you are tuning in, you are likely preparing for the ABIM exam, or, perhaps you are just looking to solidify your clinical reasoning. Either way, you are in the exact right place. Today, you are joining a dedicated board review session focused entirely on coronary artery disease, or CAD.
Which is just, it's a massive topic. We are pulling from a huge stack of sources today.
Oh, definitely.
We have the latest SIA guidelines on the management of chronic coronary disease. We are looking at landmark literature like the Syntax trial and the ischemia trial. And crucially, we have the most recent ABIM exam blueprints.
Right, which is what we all really care about, honestly.
Yep, exactly. And our mission today is very clear. Coronary artery disease is the absolute cornerstone of the board exam.
Yeah, it is inescapable.
It really is. But the boards, they do not just test rote memorization. They are not simply asking you to identify a drug class or recite a normal lab value.
No, they're testing your diagnostic branching logic. They want to see your understanding of long-term management nuance. They're designing questions specifically to see if you can navigate the algorithms when the clinical picture is deliberately blurry.
Deliberately blurry is a great way to put it. The exam specifically preys on the gray areas.
Yeah.
And those critical algorithmic decision points. They want to know if you understand not just what to do, but what to do next. And honestly, just as importantly, what absolutely not to do.
Right, the contraindications.
Yeah.
But before we get into the material, we want to invite you to like, subscribe, and share this show with your colleagues who are also preparing for the boards.
Yes, please do.
Our goal is to help elevate the standard of care across the clinical community. And, sharing this resource helps us do exactly that.
Definitely.
Okay, so let's unpack this. CAD might seem like bread and butter medicine.
Sure.
You see it every day in the clinic. You see it on the wards. You see it in the ICU. But Boardland is a very specific, almost parallel universe.
Oh, it really is.
In Boardland, a patient with CAD is a walking algorithm. Every symptom, every demographic detail, every previous medication failure, it's a carefully planted clue pointing you down a highly specific, standardized pathway.
That is exactly why it is so heavily tested. It involves incredibly high volumes of questions covering these complex multi-step management algorithms.
Right.
You are constantly required to distinguish between pain that is definitely cardiac, pain that is possibly cardiac, and pain that is definitively non-cardiac.
This is hard.
It is. And the test makers know that in real life, we sometimes rely on clinical gestalt, that gut feeling you get when you look at a patient.
You just look at them and think, uh-oh.
Exactly. But on the exam, gestalt will get you the wrong answer. You have to follow the math. Specifically, you have to follow the pretest probability.
The math. Okay, so to understand the board's mindset, we really need to look at what we call the front door of CAD.
Let's do it.
Let's look at a classic presentation. Imagine a patient walks into your clinic. Let's say a 65-year-old man. He is presenting with chest pain. He tells you it happens specifically when he walks up the 2 flights of stairs to his apartment. It feels like a heavyweight sitting on his sternum. And it completely goes away after he sits on his couch for about 5 minutes.
Classic.
Right. This is your textbook, stable chest pain.
And understanding how the boards define that specific presentation, like typical versus atypical, that literally dictates the entire diagnostic pathway.
Yeah, it sets the whole stage.
It does. To meet the strict criteria for typical angina, the pain must have 3 specific characteristics.
3 exact things.
Right. First, it has to be retrosternal chest discomfort with a characteristic quality and duration. So we are talking about that pressure, heaviness, squeezing, or tightness.
Not sharp or stabbing.
Exactly, not sharp. Second, it must be provoked by exertion or emotional stress.
Okay.
And third, it must be relieved by rest or by taking nitroglycerin. If a patient has all 3 of those, they have typical angina.
Got it. And if they don't have all 3?
If they have 2 of the 3, they have atypical angina. If they have 1 or none, it is officially categorized as non-cardiac chest pain.
So, in the case of our 65-year-old man, we have the retrosternal heaviness. It is provoked by the stairs, and it is relieved by sitting on the couch.
3 for 3.
3 for 3. We are looking at typical angina.
Which perfectly characterizes his pretest probability of having obstructive coronary artery disease.
Because he fits the mold perfectly.
Right. Pretest probability is the crucial first step. You take the history, the physical, the resting ECG, and you calculate the likelihood of disease before you order a single imaging study or blood test.
It's the Bayesian foundation of everything we do next.
Perfectly said.
But, here's where it gets really interesting, because the boards love to test exceptions.
Oh, they do?
Not everyone reads the textbook before they come to the emergency department. While classic crushing chest pain is the most common presenting symptom overall, the test writers will frequently present you with specific demographic groups.
Yes, absolutely.
Like women, older adults, and patients with diabetes. Groups who, they do not have that classic retrosternal pressure.
This is a massive area for point scoring. These populations often present with what we call anginal equivalents.
Right.
The pathophysiology here is actually fascinating. In diabetic patients, for instance, you are often dealing with cardiac autonomic neuropathy.
Ah, the nerve damage.
Exactly. The afferent nerve fibers that would normally transmit that classic pain signal to the brain, they are damaged by years of hyperglycemia.
So they don't feel the squeeze.
Right. So the ischemia is happening, the myocardium is literally starving for oxygen, but the brain doesn't register it as pain.
That is wild. So instead, they present with severe exertional dyspnea.
Yes.
A patient might say, I don't have any chest pain at all. I just suddenly can't catch my breath when I walk to the mailbox.
That's it.
Or they might present with unexplained nausea, profound diaphoresis, or just this exaggerated crushing fatigue that comes on only with exertion.
Yeah, fatigue is a huge one.
I remember seeing a case where a 70-year-old woman with long-standing diabetes complained of sudden, severe fatigue every single time she tried to vacuum her living room.
Oh, wow.
Yeah, she just had to sit down immediately. And the boards want you to recognize that as an anginal equivalent. You must treat that symptom with the exact same algorithmic respect as classic crushing chest pain.
That is such a crucial trap to avoid. Do not let the absence of the word pain in the vignette steer you away from a cardiac workup if the symptom is exertional and relieved by rest, especially in a high-risk patient.
Okay, Lee, push back on this a little bit, though.
Sure.
If the presentation can be so varied, and, if the consequences of missing CAT are so incredibly high, we're talking about myocardial infarction, heart failure, and sudden cardiac death, why don't we just stress test everyone who walks in with any kind of chest pain or anginal equivalent?
It's a fair question.
Right. Why do we care so much about perfectly calculating this pre-test probability? If the stakes are literally life and death, why not just put them all on the treadmill and find out for sure?
It is a very tempting thought process, and honestly, it is exactly the trap that many test takers fall into when they are feeling anxious during the exam.
Because you want to be safe.
Right, you want to rule out the bad stuff. But the reason we do not stress test everyone comes down to the statistical danger of false positives in low-risk patients.
Oh, okay.
This is Bayes' theorem in action. If you take a patient with a very low pretest probability, say a healthy 25-year-old woman with sharp, fleeting chest pain that happens when she twists her torso.
Which is clearly musculoskeletal.
Exactly. Giving her a pretest probability of less than 15%. If you run a stress test on her, any positive result you get is statistically far more likely to be a false positive than a true positive.
Because no test is 100% specific. There is always going to be noise in the data.
Always.
You get artifact on the imaging or minor EKG changes that really mean nothing. A false positive is not just a harmless mistake where we say, oops, our bad, you're fine.
Far from it. A false positive leads directly to a cascade of unnecessary invasive testing.
Yeah, the domino effect.
You take that low-risk patient, and now, because of an abnormal stress test, you are obligated to send them to the cath lab.
Right.
They get an invasive angiogram. Now you are physically threading catheters through their arterial system. Maybe they suffer a rare but catastrophic complication like a spontaneous coronary artery dissection from the catheter itself.
Oh, which is a nightmare.
Or an access site hematoma, a retroperitoneal bleed, or contrast-induced nephropathy. All of this morbidity, potentially even mortality, for a disease they never actually had.
Which is a massive failure of care. So the guidelines, and therefore the boards, are fiercely strict about this.
Very strict.
You only pursue testing for diagnosis in patients who fall into the intermediate zones of pretest probability. The guidelines color code this as the green and orange zones, which represent a pretest probability of 15% and above.
Right.
If they're below 15%, testing is generally not recommended unless your clinical judgment strongly dictates otherwise, like maybe due to a massive family history of premature sudden death.
Exactly. That intermediate zone is the sweet spot where the diagnostic power of the tests actually changes your management without exposing low-risk people to harm.
So let's say we do the math. We establish the pretest probability, and we decide the patient is firmly in that intermediate zone, greater than 15%.
Oh.
So if Bayes' theorem tells us this patient is in the danger zone, how do we look inside the heart without causing unnecessary harm?
That brings us to the great debate.
The great debate: coronary CT angiography versus functional stress testing. The ABIM exam loves to make you choose between visualizing the anatomy with a CT scan and testing the physiology with a stress test.
Oh, this is a major area of focus for the modern exam, reflecting recent shifts in the clinical guidelines. You have an intermediate risk patient. How do you decide?
Yeah, what's the rule?
The core rule the guidelines rely on is largely based on the patient's age and the clinical suspicion of the type of obstructive disease present.
Let's use an analogy here, because visualizing this makes it so much easier to remember.
I love analogies.
Imagine the coronary arteries are the plumbing system of a house.
A very fitting way to look at it, especially when we talk about plaque buildup.
Right. So coronary CT angiography, or CCTA, is essentially like sending a tiny high-definition camera down into the pipes of this house.
Okay.
You were looking directly at the walls of the pipes. You were looking for early buildup, the soft grime that hasn't hardened yet. This camera is absolutely fantastic at ruling out disease if the pipes are clean.
It has a phenomenal negative predictive value.
Exactly. Therefore, CCTA is the preferred test for patients younger than 65 years old, or those with a lower suspicion of severe, established obstructive CAD.
Yeah.
You were looking for soft, non-calcified plaque.
The key word there is non-calcified. But you know what happens to the pipes in a house as it gets very old?
They get nasty.
Or in a patient with long-standing diabetes and renal disease. The pipes calcify. The plaque gets covered in hard, dense mineral deposits.
Right. So if you send a camera into an 80-year-old, heavily calcified pipe, the glare from all that hard calcium completely blinds the camera. You literally cannot see the actual lumen where the blood flows.
Yeah. The technical term for this on the boards is calcium blooming artifact.
Glooming artifact, right?
The calcium scatters the beams of the CT scanner, making the plaque look much larger and more obstructive than it actually might be. So the anatomical camera becomes useless for determining true stenosis.
So what do?
Instead of a camera, you need a functional test. You need to turn all the faucets in the house on full blast and see if the actual water pressure drops at the end of the line.
I love that. Turning the faucets on full blast. That functional test is the stress test.
Exactly.
You're stressing the system to see if the physiological flow is compromised when demand goes up. And that is why stress testing is preferred for patients 65 and older, or those with a higher clinical suspicion of widespread obstructive CAD.
Because their vessels are more likely to be heavily calcified, making the CCTA unreliable.
Right. The stress test does not care about the calcium glare. It only cares about one thing. Can the blood flow adequately when the heart muscle demands it?
Precisely.
Okay, so if we decide to go with the functional route, we're turning the faucets on full blast, we still have a massive decision to make.
Yes, we do.
We have to choose which stress test to use. The boards will give you a multiple choice list: exercise EKG, stress echocardiogram, or a nuclear SPECT scan. Let's break this down because you cannot just pick one at random.
No, you absolutely cannot. The absolute primary distinction here revolves around the patient's baseline resting EKG.
Okay.
A standard exercise treadmill EKG is the cheapest, most accessible, and honestly most physiological test. But it relies entirely on your ability to read ST segment changes, specifically ST depressions, during the peak of exercise.
Right.
Therefore, you can only use an exercise EKG if the patient has a perfectly normal baseline EKG and, crucially, is physically capable of walking briskly on a treadmill.
Which is a classic board trap.
Huge trap.
If the baseline EKG is already abnormal, the exercise EKG becomes completely uninterpretable. For example, if they have left ventricular hypertrophy with repolarization strain patterns.
Or if they have a paced ventricular rhythm from a pacemaker.
Right. Or if they just have more than 1 millimeter of ST depression at baseline, you cannot read the test. The baseline is already skewed.
Exactly. You won't know if the ST changes during exercise are due to new ischemia or just, an exaggeration of their baseline abnormality.
So what's the move when the EKG is unreadable?
In those cases where the EKG is uninterpretable or if the patient is at a higher risk of false positives, you must add imaging to the stress test.
Okay, imaging.
You do the stress portion, either by having them exercise or by giving them a pharmacologic agent if they have bad knees and can't walk, and then you physically image the heart.
Like with an echo.
Yes.
Wow.
You can use echocardiography to look for stress-induced regional wall motion abnormalities. Essentially, you are looking to see if a segment of the left ventricle stops squeezing when it gets starved of oxygen.
Or you can use a nuclear SPECT scan, which stands for single photon emission computed tomography.
Yes, myocardial perfusion imaging.
Right. You inject a radioactive tracer, like technetium 99 meters, at peak stress. The tracer flows where the blood flows. If there is a blockage, the tissue downstream won't get the tracer, and it will show up as a dark defect or cold spot on the scan.
Exactly.
Then you compare it to a resting scan. If the defect is there during stress but fills in during rest, that is reversible ischemia.
That's the one we worry about.
But if the defect is there during both stress and rest, that is a dead zone, a prior myocardial infarction, scar tissue.
Understanding that distinction between anatomy and function and knowing exactly when to deploy imaging over a simple EKG is fundamental to passing the CAD section of the exam.
It really is. So we have navigated the diagnostic maze. We have confirmed the diagnosis of stable coronary artery disease. What's the next step?
Yeah, we have to manage it.
We have to manage it. This brings us to the bedrock of chronic care, guideline-directed medical therapy, or GDMT.
The Holy Grail.
The boards will test you on the nuances of every single class of medication here. Let's start with the foundational layers, antiplatelets and statins.
Right. For stable chronic CAD, the antiplatelet therapy is generally straightforward. Low-dose aspirin, typically 75 to 162 milligrams daily, with 81 milligrams being the standard in the U.S.
Baby aspirin.
Exactly.
Mm-hmm.
The mechanism here is the irreversible acetylation and inhibition of the COX-1 enzyme in platelets.
Which prevents them from synthesizing thromboxane A2, right?
Yes, which is a potent inducer of platelet aggregation. We use low dose because it is sufficient to inhibit the platelets in the portal circulation before the aspirin is heavily metabolized by the liver, while sparing enough of the COX enzymes in the systemic circulation to maintain the protective prostaglandins in the stomach lining.
That's such a neat physiological trick.
It really is.
And if they have a true aspirin allergy like actual anaphylaxis or severe bronchospasm, what is the move?
Clopidogrel is your acceptable alternative. It is an ADP receptor inhibitor, specifically blocking the P2Y12 receptor on the platelet surface.
Okay,
But a massive point to remember. You do not use the newer, more potent P2Y12 inhibitors like prasugrel or ticagrelor for stable chronic CAD.
What?
Those agents are strictly reserved for acute coronary syndromes or the immediate post-stent management phase.
Because the bleeding risk of those potent agents massively outweighs the ischemic benefit in a stable outpatient.
Exactly. You're just asking for bleeding complications.
Okay, now what about the statin? This is a place where old-school clinical habits often clash with modern board answers.
Yes, they do. High-intensity statin therapy is absolutely required. That means atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. Here's the pearl. High-intensity statins are required in established CAD regardless of the baseline LDL cholesterol level.
I cannot emphasize that enough for you listening. The question stem will deliberately try to trick you.
They absolutely will.
They will present a 60-year-old man with known CAD who has a beautifully controlled LDL of 65 on a moderate intensity statin like simvastatin 20 milligram. They'll ask what the next best step is.
And you want to say continue current management.
Right. The instinct is to say that because the LDL looks great. But the answer is to switch to a high-intensity statin. Period. Why?
Because it is not just about the lipid-lowering numbers. It is about the pleiotropic effects of the high-intensity statin.
Ah, the pleiotropic effects.
Yes. They stabilize the fibrous cap of the atherosclerotic plaque, physically preventing it from rupturing. They dramatically reduce inflammation within the arterial wall by lowering CRP levels, and they upregulate endothelial nitric oxide synthase, which improves the vasodilation of the coronary arteries.
So they're doing a lot more than just lowering cholesterol.
Exactly. The mortality benefit of high-intensity statins in secondary prevention is proven, irrespective of the starting LDL.
Okay, now let's talk about symptom control. A patient is having angina. What is the anti-anginal of choice?
Beta blockers are the definitive first-line agents for anti-anginal therapy.
The pathophysiology here is so elegant.
It is.
Angina is fundamentally a supply and demand mismatch. Beta blockers, specifically beta-1 selective agents like metoprolol or bisoprolol, decrease myocardial oxygen demand by lowering the heart rate and reducing the force of contractility.
Right. But the crucial secondary benefit is that by slowing the heart rate, you prolong diastole.
Coronary perfusion occurs almost entirely during diastole.
Exactly.
When the heart muscle relaxes, blood can actually flow through the coronaries. If the heart is racing at 100 beats per minute, diastole is incredibly short, and the subendocardium just starves.
It does. And the clinical goal, which you absolutely will see tested, is to titrate the beta blocker to achieve a resting heart rate of 55 to 60 beats per minute.
55 to 60.
Yes, if the vignette shows a patient with angina on metoprolol, but their heart rate is 75, they are not fully optimized.
Precisely. You must optimize the first-line agent before adding a second-line agent like a calcium channel blocker or a long-acting nitrate.
Right, don't jump to adding drugs when the first one isn't maxed out.
So what does this all mean for ACE inhibitors and ARBs? ARBs, of course, being angiotensin the receptor blockers. I feel like in the hospital, every single patient with any history of heart disease is automatically placed on lisinopril or losartan.
Right. In the real world, it often seems that way. But on the ABIM exam, you must be incredibly precise with your indications.
Okay.
ACE inhibitors and ARBs are not automatically indicated for every single patient with stable CAD. They have specific, heavily tested indications centered around the need to prevent negative cardiac remodeling.
Remodeling. So if the patient just has stable angina, completely normal kidney function, no diabetes, and the normal ejection fraction of 60%, the renin-angiotensin-aldosterone system isn't the primary driver of their pathology.
Exactly. You add an ACE inhibitor or an ARB if the CAD patient also has concomitant diabetes, chronic kidney disease, an ejection fraction of 40% or less, or clinical heart failure.
Got it.
In those specific scenarios, blocking the RAAS pathway prevents the left ventricle from dilating and failing over time, and it protects the nephrons. But for uncomplicated stable angina, an ACE inhibitor is not going to improve their survival, and it is the wrong answer on the test.
Good to know. So we've covered the medical foundation. Let's look at risk stratification. We briefly mentioned the coronary artery calcium score, or CAC score, earlier.
Yeah, very useful test.
This is a non-contrast CT scan that just looks for the presence of calcium in the coronaries. It's used to refine that pretest likelihood we talked about. If a patient is in that low to intermediate gray zone, a CAC score of 0 can powerfully downgrade their risk.
Absolutely. It suggests a near zero event rate over the next few years, often allowing you to skip further testing entirely.
But what about the other end of the spectrum? When do we abandon all the non-invasive tests, the CTs, the treadmills, the echo, and send the patient straight to invasive coronary angiography in the cath lab?
You bypass the non-invasive workup and go straight to invasive angiography when the patient is exhibiting high-risk features that suggest impending catastrophic failure.
Like what?
This can be determined clinically. For example, a patient who has refractory angina despite being on maximal GDMT.
Right.
If they are already taking an optimized beta blocker, a calcium channel blocker, and a long-acting nitrate, and they still cannot walk from their bedroom to the kitchen without severe chest pain, you do not need a treadmill test to tell you they have severe flow-limiting disease.
Yeah, that's pretty obvious.
You go straight to the cath lab for potential revascularization.
The boards will also give you scenarios where a patient had a prior non-invasive test that showed terrifying high-risk findings.
Yes. If a prior echocardiogram or nuclear scan showed a resting left ventricular ejection fraction less than 45% in the setting of known CAD, that is a high-risk feature.
Right.
Or if a stress test shows large fixed perfusion defects or stress-induced transient LV cavity dilatation, which is a fascinating phenomenon.
Oh, I love the physiology of transient ischemic dilation. It implies that the ischemia during stress is so globally severe across the subendocardium that the left ventricle temporarily fails to squeeze and the cavity actually balloons outward, filling with blood.
Yes, the heart literally dilates acutely under stress.
If you see that on a report in the question stem, do not order another test. That is an automatic trigger for invasive angiography to define the anatomy for possible bypass surgery.
Exactly. Do not pass go.
Okay, we have covered the deep theory, the pretest probabilities, the diagnostic branching, and the medical therapy. But theory only goes so far until you apply it.
True.
So let's take all of this theoretical pathophysiology and put it on the wards. Imagine you are rounding. We are going to simulate a rapid-fire teaching session.
Sounds fun.
We're going to test your application of these algorithms with 8 specific ABIM-style board vignettes. Let's dive right in. Case 1, the conduction defect. You are evaluating a 68-year-old woman who is presenting with stable exertional chest pain. You get a baseline resting EKG in the clinic, and it shows a classic left bundle branch block, an LBBB.
Okay, LBB.
You calculate her risk, and you decide she needs a functional evaluation for ischemia. What is the next best step?
The correct answer here is a pharmacologic vasodilator stress test using an agent like adenosine, regadenosin, or dipyridamole paired with myocardial perfusion imaging like a SPECT scan.
Let's unpack the logic here. Why do they absolutely need a vasodilator stress test and not an exercise EKG? The distractors on the test will definitely offer exercise EKG and dobutamine stress echo as options.
They always do.
Let's dismantle the exercise EKG first.
Exercise EKG is completely incorrect because of the electrophysiology of the left bundle branch block. In an LBBB, the left ventricle depolarizes late and abnormally, which fundamentally alters the repolarization phase, the ST segment and the T wave.
Right. It's already a mess.
It completely obscures the ST segment depressions that you rely on to diagnose subendocardial ischemia during exercise. You literally cannot read the ischemic changes because the baseline repolarization is so wildly abnormal.
Okay, so we need imaging. But why not a dobutamine stress echo or just putting her on a treadmill with imaging? Why must it be a vasodilator? This is a massive physiological trap.
This comes down to the mechanics of the interventricular septum. If you elevate the heart rate significantly in a patient with an LBBB, whether by having them run on a treadmill or by giving them dobutamine, which is an inotrope and chronotrope that mimics exercise, the uncoordinated contraction of the ventricles causes the septum to move paradoxically.
A septal bounce.
Exactly. Instead of thickening and moving inward during systole, it bulges abnormally. On a nuclear perfusion scan, this abnormal rapid septal motion actually creates a false positive perfusion defect in the septum.
Oh, wow.
Yeah, it looks exactly like an ischemic blockage in the LAD, but it's just an artifact of the heart rate and the bundle branch block.
To avoid this artifact, you must use a vasodilator, like adenosine. Adenosine works directly on the A2A receptors in the coronary vasculature, causing profound dilation of the normal coronary arteries, which steals blood flow away from the diseased, already maximally dilated arteries.
Right.
Crucially, adenosine does this without significantly raising the heart rate. By keeping the heart rate low, the septum doesn't bounce around as violently, allowing you to accurately image the true perfusion without the artifact.
It is a beautiful intersection of electrophysiology, mechanics, and pharmacology.
Absolutely. Moving to case 2. The maxed out patient.
Okay.
A 72-year-old man with known established CAD complains of ongoing stable angina. It is happening a few times a week, severely limiting his ability to work in his garden.
Poor guy.
You look at his medication list. He is already on maximal tolerated doses of a beta blocker, let's say metoprolol, succinate 200 milligrams, and a calcium channel blocker, amlodipine 10 milligrams.
Thanks.
You check his vitals in the clinic. His blood pressure is soft, let's say 105/65, and his resting heart rate is a perfectly optimized 58 beats per minute. What is the next best step in his medical management?
The correct answer is to add ranolazine.
Let's break down why ranolazine is the specific key that unlocks this question. The distractors will offer things like titrate the beta blocker higher, add a long-acting nitrate, or add an ACE inhibitor.
Titrating the traditional medications up or adding a nitrate is entirely incorrect here because of the patient's hemodynamics.
Yeah, his numbers are low.
His blood pressure is already soft at 105/65, and his heart rate is perfectly at goal at 58. If you give him more beta blocker, he becomes bradycardic and symptomatic.
Right.
If you give him a long-acting nitrate, which is a potent vasodilator, his preload drops his blood pressure tanks and he passes out in his garden. We need an anti-anginal that does not touch the hemodynamics.
Enter ranolazine. The mechanism of ranolazine is utterly unique.
It really is.
It does not lower heart rate. It does not dilate blood vessels. It works at the cellular level by inhibiting the late inward sodium current in the myocardium.
Right.
During ischemia, the myocytes get starved of oxygen, and this late sodium current stays open too long, leading to a massive intracellular buildup of sodium. The cell tries to pump this sodium out using the sodium-calcium exchanger, but in doing so, it pulls massive amounts of calcium into the cell.
Which is bad news.
Terrible news. This calcium overload prevents the heart muscle from relaxing during diastole, increasing wall tension, which compresses the microvasculature and worsens the ischemia. Ranolazine blocks that late sodium current, preventing the calcium overload and allowing the muscle to relax. The beautiful thing is that it does this without affecting blood pressure or heart rate at all.
It is the perfect add-on for the hemodynamically maxed out patient. But there is a major caveat you must watch out for in the question stem regarding ranolazine.
Yes, the side effects and interactions. You must watch the EKG for QT prolongation. Ranolazine blocks the rapid delayed rectifier potassium current, which stretches the QT interval, increasing the risk of torsades de pointe. Furthermore, ranolazine is heavily metabolized by the liver via the CYP3A4 enzyme system.
So drug interactions are huge.
You must strictly avoid ranolazine in patients taking strong CYP3A4 inhibitors. The boards love to test drug interactions. If the patient is taking clarithromycin for an infection, or certain azole antifungals like ketoconazole or protease inhibitors for HIV, those drugs will block the CYP3A4 enzyme,
Which causes ranolazine levels in the blood to spike dangerously high.
leading to massive QT prolongation and potentially fatal arrhythmias.
It's a phenomenal integration of pharmacology and clinical management.
Let's keep the momentum going. Case 3, the syntax logic.
Okay, this is a big one.
A 64-year-old man with a long-standing history of type 2 diabetes presents with worsening angina. He undergoes invasive coronary angiography in the cath lab, which reveals severe, complex three-vessel disease.
3 vessels, got it.
Specifically, the blockages include the proximal left anterior descending artery, the LAD, often called the widowmaker. The question asked for the most appropriate revascularization strategy for this specific patient.
The correct answer is coronary artery bypass grafting, or CABG.
The distractor here will absolutely be PCI percutaneous coronary intervention, which means going in with wires and balloons and deploying multiple drug-eluting stents. Why is PCI the wrong choice for this patient?
PCI with stents is incorrect because in this specific population, the historical trial data, specifically the landmark syntax trial and the freedom trial, is incredibly clear.
Undeniably clear.
CABG is proven to significantly lower the rates of repeat revascularization, and crucially, it improves overall survival. We are talking about reducing the composite endpoints of death, myocardial infarction, and stroke. This survival benefit is seen specifically in diabetic patients with multivessel disease.
Why does diabetes change the arithmetic so drastically? It comes down to the nature of the plaque. Diabetic patients do not just have discrete focal blockages that are easy to stent. They have diffuse, incredibly calcified atherosclerotic disease that runs the entire length of the vessel. If you try to stent that, you are just laying metal across long segments of diseased endothelium, which has a very high rate of in-stent restenosis and failure.
Exactly.
CABG bypasses the entire disease segment entirely by attaching a clean conduit, like the internal mammary artery, distal to the blockages.
Yeah.
The boards want you to recognize this algorithm immediately. Multivessel disease plus diabetes equals CABG.
It is one of the most reliable algorithmic rules on the exam.
Okay, let's look at case 4, the
Right.
tricky ACS timing. This is a classic trap that catches even seasoned residents.
Oh, yeah, I've seen this happen.
A 55-year-old woman presents in the emergency department with severe crushing chest pain radiating to her jaw. Her ECG shows significant ST segment depressions in the anterior leads, and her high-sensitivity troponin is markedly elevated.
Okay, so in STEMI.
Exactly. She is diagnosed with a non-ST elevation myocardial infarction, and in STEMI. Despite being given the standard medical therapy aspirin, a P2Y12 inhibitor, a heparin drip, and intravenous nitroglycerin, her chest pain is completely refractory, and her blood pressure is starting to drop to 85/50.
She's crashing.
What is the next best step?
The correct answer is urgent invasive coronary angiography in the cath lab, typically mandated within 2 hours for this level of hemodynamic instability.
The distractor answer that catches so many people is administer thrombolytics, like TPA, tissue plasminogen activator.
Yes.
Let's explore why that is so dangerously wrong. It feels like an emergency, the patient is crashing, they're having a heart attack. Why not give the powerful clot-busting drug right now?
This is an absolute red line rule in cardiology. Systemic thrombolytics are strictly contraindicated and have zero benefit in non-ST elevation acute coronary syndrome.
Zero benefit.
It comes down to the microscopic architecture of the clot. In an STEMI, the coronary artery is usually only partially occluded. The obstruction is typically a platelet-rich white thrombus. Thrombolytics like TPA are designed to break down fibrin-rich red thrombi, which are what cause total occlusions in a STEMI.
Right. If you give systemic TPA to a patient with a partially occlusive platelet-rich and STEMI clot, you not only fail to dissolve the blockage, but you also paradoxically increase the risk of plaque hemorrhage.
Which is terrifying.
You can actually cause the plaque to rupture further, converting a partial occlusion into a catastrophic total occlusion. And that is on top of exposing the patient to a massive risk of intracranial hemorrhage for absolutely no benefit.
Right. You only use thrombolytics in a full-blown STEMI when a cath lab is geographically unavailable within 120 minutes. For a crashing, unstable STEMI, you must push them directly to the cath lab for mechanical intervention with wires and stents.
Exactly the kind of mechanistic understanding the boards require. Moving on to case 5, the post-MI complication.
Let's do it.
A 68-year-old man is admitted with a large inferior STEMI. He is taken to the cath lab, treated with PCI, and a stent is successfully placed in his right coronary artery.
Okay, successful stent.
4 days later, while he is recovering on the telemetry floor and doing well, he suddenly develops profound hypotension, tachycardia, and signs of cardiogenic shock.
Uh-oh.
You rush to the room and listen to his chest. His lungs are clear, but you hear a loud, harsh, new holosystolic murmur at the left lower sternal border, accompanied by a palpable thrill. This murmur was absolutely not there yesterday. What is the next best step?
You need to obtain an urgent echocardiogram at the bedside, followed by an immediate surgical evaluation for a ventricular septal defect, a VSD.
The distractors will offer medical management with aggressive afterload reduction and intravenous diuretics. Why is conservative medical management the wrong path here?
The timeline and the physical exam are the massive clues. This is a mechanical complication of a myocardial infarction. When the myocardium dies, it undergoes coagulative necrosis.
Right, the tissue dies.
Around days 3 to 5 post-infarct, macrophages infiltrate the area to clear out the dead tissue. This process dramatically softens the ventricular wall before strong fibrotic scar tissue has a chance to form.
It turns to mush.
Exactly. If the infarct involved the interventricular septum, that softened tissue can literally tear open under the high pressure of the left ventricle.
And that tear creates an acquired ventricular septal defect. The left ventricle is now pumping high-pressure blood directly across the septum into the low-pressure right ventricle during every systole, which creates that incredible turbulence, resulting in the loud, harsh, holosystolic murmur.
Right.
Medical management alone is deeply incorrect because the mortality of a medically managed post-infarct VSD approaches 100%. The fundamental problem is not neurohormonal, it is mechanical.
The pump has a hole in it.
The pump has a hole in it. You cannot fix a physical hole in the heart with a pill. They need structural repair, usually open heart surgery, to patch the defect, to have any chance of survival.
Recognizing the timeline day 3 to 5 and matching it with the specific murmur is a guaranteed board point.
Let's stick with complications for case 6. The right ventricular infarct.
Oh, this one is tricky.
A 60-year-old man presents to the emergency room with an inferior MI. His EKG shows ST elevations in leads 2, 3, and AVF. His blood pressure in the ER is dangerously low, 80/50.
Okay.
You examine him. His jugular veins are massively distended, with the JVD visible all the way up to his earlobes while sitting at 45 degrees. But, crucially, you listen to his lungs and they are completely clear. No crackles, no fluid. What is the next best step in his acute management?
The correct answer is intravenous volume resuscitation, giving him a rapid bolus of normal saline.
The classic fatal distractor here is administer sublingual nitroglycerin or start an IV nitroglycerin drip. Most chest pain protocols include nitroglycerin. Why is giving nitro to this specific patient a terrible, potentially lethal idea?
Because the presentation hypotension, massively elevated JVD, and clear lungs in the setting of an inferior MI is the classic triad for a right ventricular infarct. The right coronary artery often supplies the right ventricle. When it occludes, the right ventricle becomes ischemic, severely stunned, and fails to pump blood forward into the lungs.
So, if the right ventricle can't squeeze, how does blood get to the left side of the heart to maintain cardiac output?
It becomes entirely dependent on venous return preload.
Preload.
Yes. The pressure of the venous blood returning from the body physically pushes the blood through the stunned right ventricle. Sublingual nitroglycerin is a potent venodilator. If you give it, you drastically expand the venous capacitance vessels.
Oh boy.
You will pool all of their blood in their legs and splanchnic system, completely wiping out the preload that the right ventricle is desperately relying on. You will cause profound, potentially fatal cardiovascular collapse.
That is wild.
Instead, you do the opposite. You give IV fluids to increase the preload and physically force blood through that failing right side.
It's all about recognizing that the right ventricle operates on completely different hemodynamic principles than the left ventricle during an infarct. Case 7. The atypical STEMI presentation.
Okay.
A 32-year-old woman who is 2 weeks postpartum presents to the emergency department with sudden, severe, tearing chest pain. Her ECG shows classic ST elevation in the anterior leads, and her high-sensitivity troponins are sky-high. She is rushed emergently to the cath lab, assuming it is a standard plaque rupture.
Because why wouldn't you?
What is the most likely diagnosis, and what is the appropriate management once the anatomy is visualized?
Given her demographics, you must immediately suspect spontaneous coronary artery dissection, or SCAD.
SCAD.
When the angiogram confirms it, crucially, unless she has incredibly high-risk anatomy like left main involvement or is hemodynamically crashing, the correct management is conservative. Medical therapy, beta blockers to reduce shear stress, and close observation.
Wait, hold on. She is having a STEMI. The EKG shows ST elevation. The distractor on the test is going to be immediate aggressive stenting with PCI. Everything we learned says STEMI equals immediate PCI to open the vessel. Why is stenting the wrong answer here?
Because the underlying pathophysiology is entirely different from a standard heart attack. This is not an atherosclerotic plaque rupture filled with cholesterol and platelets.
Right.
In SCAD, an intimal tear occurs in the wall of the artery, often related to the extreme hormonal changes and vascular stress of pregnancy, or underlying conditions like fibromuscular dysplasia. Blood dissects into the arterial wall, creating a massive intramural hematoma that bulges inward, compressing the true lumen and starving the heart muscle.
Wow.
If you go into that fragile, torn vessel with stiff wires and high-pressure balloons to place a stent, that acute vascular manipulation can easily propagate the tear. You can extend the hematoma and the dissection further down the artery, turning a localized problem into a catastrophic full-vessel occlusion.
Which is the exact opposite of what you want to do.
Exactly. The data shows that these vessels are incredibly friable, but they also have a remarkable capacity to heal on their own once the acute stress passes. So, counterintuitively, doing less is often more in SCAD. You manage them conservatively unless they are actively dying in front of you.
That is a phenomenal board pearl that perfectly illustrates how pathophysiology dictates management.
It really does.
Last case, case 8, the supply-demand mismatch.
Let's hear it.
You were consulted by the intensivist in the ICU. An 80-year-old patient is admitted with severe urosepsis. His blood pressure is 85/40, his heart rate is 140 beats per minute, and he has a fever of 103 Fahrenheit.
Sick patient.
Very sick. The primary team checked a routine troponin, and it is elevated. They are panicking about a heart attack. However, you look at his EKG, and it shows only sinus tachycardia, no ST depressions, no T-wave inversions. When he is lucid, he denies any chest pain whatsoever. What is the next best step?
The correct answer is to ignore the heart for a moment and vigorously treat the underlying urosepsis with IV fluids, pressors, and broad-spectrum antibiotics. This patient is experiencing a type 2 myocardial infarction.
The aggressive distractor will be transferred to the cath lab for emergent coronary angiography or start a heparin drip for STEMI. Why do we leave his heart alone and focus on the infection?
Because there is no acute atherothrombotic event here. There is no unstable plaque that has suddenly ruptured. A type 2 MI is entirely a supply and demand mismatch.
Okay, explain that.
Think about the hemodynamics. His heart is racing at 140 beats per minute to try and compensate for the sepsis, which dramatically increases the myocardial oxygen demand. At the same time, his blood pressure is 85/40, which means his diastolic pressure is terribly low.
And coronary perfusion happens in diastole.
Exactly. Since coronary perfusion happens in diastole, his oxygen supply is drastically reduced.
The myocardium is simply starving for oxygen because of the extreme physiological stress of the sepsis, hence the leak of troponin from the stressed myocytes. Going to the cath lab does absolutely nothing to fix the sepsis. There is no clot to stent, and you are only exposing a critically ill, unstable patient to the immense risks of contrast dye and invasive procedures.
Right.
Fix the supply and demand mismatch by treating the root cause, the infection.
That perfectly encapsulates the concept of treating the patient, not just the lab value.
Wow. We just ran an incredible gauntlet. If you can navigate the underlying logic of those 8 cases, you are in phenomenal shape for the clinical vignettes on test day. Now, let's pivot and distill this even further. Let's look at the absolute highest yield testable facts, the isolated pearls that can get you a quick point.
Here's something the boards love to ask. They love to test your understanding of the difference between the best initial test and the gold standard.
Oh, yes.
We spent a lot of time talking about CCTA and functional stress testing. Those are your best initial non-invasive tests for the functional or anatomic workup of stable disease in an outpatient setting. But do not forget, if the question asks for the gold standard or the definitive test, invasive coronary angiography remains the gold standard for defining coronary anatomy, especially if the patient is high risk.
Let's talk about contraindications. The never do this list. We already covered the lethal combination of nitroglycerin and right ventricular infarcts. What else makes the list?
Never give nitrates of any kind to a patient who has used a PDE5 inhibitor like sildenafil or tadalafil in the last 24 to 48 hours.
The Viagra trap.
Exactly. Both of these drugs work by dramatically increasing intracellular cGMP levels in the vascular smooth muscle, causing profound relaxation. If you combine them, the synergistic effect causes catastrophic, completely refractory hypotension that is incredibly difficult to reverse.
What about the classic toxicology crossover? Cocaine.
Never give pure, unopposed beta blockers in a patient with acute cocaine-induced vasospasm and chest pain.
Unopposed alpha.
Right. Cocaine stimulates both alpha-1 and beta-2 receptors. The beta-2 receptors normally provide some degree of vasodilation to counteract the alpha-1 vasoconstriction. If you give a pure beta blocker, you block that protective vasodilation, leaving the alpha-adrenergic receptors completely unopposed.
Which is bad.
Very bad. This leads to massive paradoxical coronary vasoconstriction, severely worsening the hypertensive crisis and the myocardial ischemia. If you must lower the heart rate, you use a mixed alpha-beta blocker, or better yet, benzodiazepines to calm the central nervous system.
And what about our heart failure patients who have angina?
Never use non-dihydropyridine calcium channel blockers, specifically verapamil and diltiazem in patients with known left ventricular dysfunction or heart failure with reduced ejection fraction.
Why is that?
These specific drugs are potent negative inotropes. They directly weaken the mechanical squeeze of the heart muscle. In a patient whose squeeze is already failing, giving verapamil can push them straight into acute decompensated heart failure or cardiogenic shock.
Those are absolute lifesavers on the exam. Let's look at mortality predictors and high-risk ECG signs. When you are looking at a stress test report in a vignette, what findings should make you stop in your tracks?
A drop in blood pressure during a stress test is a massive red flag. Normally, as you exercise and your sympathetic nervous system kicks in, your blood pressure shouldn't actually rise.
Right.
If it drops during exertion, it means the ischemia is so globally profound across the myocardium that the left ventricle is acutely failing to maintain cardiac output under stress. That almost always points to severe left main disease or critical multivessel disease.
And on the EKG. The boards love showing visual exhibits and asking for the next step.
There are two eponymous signs to burn into your brain. First, the De Winter sign. This presents as tall, prominent, symmetric T waves arising directly from upsloping ST depression at the J point in the precordial leads.
Upsloping ST depression.
Yeah. It looks a bit like the peaked T waves of hyperkalemia, but in the clinical setting of chest pain, it is a stealthy indicator of a critical proximal LAD occlusion. It is a STEMI equivalent.
And the second.
Whelan sign. This is characterized by deep, symmetrical T-wave inversions, or sometimes biphasic T-waves, in the anterior leads, primarily V2 and V3.
Whelan's.
The major catch here is that the patient may be completely pain-free at the exact moment the EKG is taken. The ST segments might be perfectly isoelectric, but that specific T-wave pattern means the proximal LAD has a highly unstable lesion that is critically stenosed and is intermittently occluding and reperfusing.
Wow.
Both De Winter and Whelan's are massive red flags for impending catastrophic anterior wall myocardial infarction, and they warrant urgent cath lab evaluation.
Unbelievably high yield. Okay, we are entering the final stretch of our session. We are going to bring the energy up for a rapid board review summary. We are going to deliver 5 precise, concise takeaways to lock in your memory for test day. These are fast pattern recognition facts. Ready?
Let's do it.
If you see a patient with severe reactive airway disease, like poorly controlled asthma, who has stable CAD and requires a stress test.
Think exercise stress or dobutamine over adenosine or regadenoson. The pharmacologic vasodilators can trigger severe, life-threatening bronchospasm in asthmatic patients.
If you see a diabetic patient with severe 3-vessel disease on angiography.
The answer for revascularization is almost always coronary artery bypass grafting, CIBG, not PCI with stents, to improve long-term survival.
The absolute first-line agent for symptom control and stable ischemic heart disease is
always a beta blocker. And remember the goal. Titrate to a resting heart rate of 55 to 60 beats per minute.
If you see a rise and fall of troponins with absolutely no clinical signs of ischemia, no pain, no EKG changes, no echo wall motion abnormalities.
Think acute myocardial injury due to supply-demand mismatch, perhaps related to renal failure, heart failure, or sepsis. Focus on treating the underlying systemic cause, not an acute plaque rupture.
If an older adult presents with sudden syncope and pulseless electrical activity, 4 days after a large anterior MI.
Suspect left ventricular free wall rupture leading to catastrophic cardiac tamponade.
Phenomenal. To close out our board review session today, I want to summarize the single most important concept we have covered regarding stable CAD. It is a concept that governs everything from the outpatient clinic to the cath lab. Guideline-directed medical therapy, or GDMT, must be fully optimized before you consider revascularization in stable disease.
Crucial point.
You must internalize this. Unless a patient has specific high-risk anatomic criteria like critical left main disease or multivessel disease with a significantly reduced ejection fraction, putting a stent in a stable patient does not prevent heart attacks, and it does not extend their life.
Yeah.
PCI does not improve survival over maximal medical therapy in stable angina. It only helps relieve symptoms. Optimize the medications first. That is the rule.
That is the cornerstone of modern cardiology guidelines, proven by trials like Courage and Ischemia.
Now, I want to leave you with a provocative thought, something that is right on the cutting edge of where the guidelines are heading, and something you might see creeping into future board exam iterations. We talked about how the guidelines currently do not recommend routine stress testing or CAC scoring in asymptomatic diabetics.
Right.
We generally don't go looking for trouble if they don't have symptoms. But with the massive rise in high-resolution chest CT scans for lung cancer screening and other pulmonary reasons, we're stumbling upon an incidental finding all the time: silent myocardial ischemia.
Yeah, we see it a lot now.
We are seeing incredibly heavy calcification and severe coronary disease on imaging before the patient ever feels a single twinge of chest pain. How will this change the definition of asymptomatic in the future? If we can literally see the advanced disease on a scan, should we be aggressively putting these patients on high-intensity statins, aspirin, and perhaps even beta blockers before they ever complain of angina? It is a fascinating question that challenges our current strict algorithmic boundaries.
It absolutely challenges the paradigm. It completely blurs the traditional line between primary prevention and secondary prevention.
It certainly does. Well, that is all the time we have. Thanks for joining us for this board review edition. Don't forget to like, subscribe, and share for the benefit of your peers.
Good luck with your studying.
See you at the bedside.